This is key pediatric nursing interventions except for calculating fluid maintenance and safe medication dose ranges. That's in Unit 1 under, it's just called Med Math. So when we give medications to kids, we use those same rites. There's 5 of them that you have to do before administering the med. Write medication, look at it. Some medications have similar names, so look closely. Write patient. Some patients have similar names. Look closely. Write time, write route, and the right dose. We do have the scanners now to help ensure that we're giving medication safely, but it's still our job to look and think about it. You're going to do the same education as you give medications to kids that you do with adults, of telling them what the medication is and what it's for, but think what that child's developmental level is and what can they understand. You're going to have to simplify it. So why do they need this drug? This is to kill the infection, or this is to make you go pee more. So what are you going to experience? Well, if we're giving it in the IV, you're not going to feel it because we're giving it up here, but the pump's going to beep in half an hour. So you have to come back to your room so I can flush the line, or make sure that they know what's going on in a way they understand, and involve the parents as well. So how does meds come for kids? Well, we use a lot of liquids for our oral meds. Elixirs, syrups, suspensions, that's just different ways that the pharmacy makes it. All of them, make sure you shake them up before you use them. You don't want the med to settle and you've taken it off the top, or you've given them all syrup without med in it. We have powders, tablets, capsules. Capsules, a lot of them will open and dump out. Maybe dissolve it in water, or maybe put it on a spoonful of purees or applesauce or something. Meds also that we use with kids also come powders and aerosols. There's topicals, creams, ointments, lotions, drops, patches, rectal suppositories. When we're giving an oral medication, make sure you're measuring it accurately. Syringe is usually the best, and make sure the parent knows how to do that. If we send them home saying a teaspoon and they just use the spoon from their drawer, that's not an accurate teaspoon. So usually we send them home with a syringe, and we usually mark on there with a Sharpie where they should be drawing it up to. And then when you give meds to kids, we want them sitting up. If they're laying flat, they're at risk for aspirating that medication. And when you give it, see how it's being given kind of in the cheek towards the back. If you put it right in the front of the mouth, it's really easy to spit out. And give a small amount at a time, because if the child does get it spit out, we don't want them spitting out the entire dose. We give a lot of meds through gastrostomy tubes, and then we have a lot of jejuostomy tubes, so into the jejunum, not just the stomach. So know your policy, but usually it's going to have you verify the placement. Give it directly. Our meds come in a syringe, so we can just hook that syringe up and give it. Know your policy again. Do you follow it with a little air or a little water? If it's a powder, how much water do you need to mix it in? If it's a pill, crush it as much as you can, but realize enteric-coated and time-released cannot be crushed. Capsules, as I said, open it, dump it out, mix it in some water. If it's something that can't be dissolved, or it's got pieces that are enteric-coated or something, then we're going to have to do it in a spoon of whatever, something else. And then flush after. Be careful how much you mix things in and how much you flush with water, because a baby's stomach is not that big, and we can have a huge volume here that's then going to make them reflux and put them at risk for aspirating. Here's a couple of pictures of gastrostomy tubes. The one on top is your traditional gastrostomy tube, and that piece is always hanging out. We don't use those very often at Children's. This is what we use, the button, and we use the Mickey brand. This is the skin here, right? So this is all you see above the skin. This pulls over and snaps shut like a beach ball, and then you open it. There's an extension that hooks on here, and you put the med onto the extension, it won't hook directly onto that. But the nice thing is when it's not in use, there's nothing hanging out. And then this is inside the stomach, and it's got an inflated balloon here to hold it in place. Ophthalmic, you're going to do just like with the adult, pull down on that lower lid to make your conjunctival sac, drop in either your drops or put the ointment along the underside of the eyelid there along the conjunctiva, but be careful not to touch the tips because you don't want to contaminate the rest of that tube or the drops. When you're giving an ear drop, this shows you which way of pulling the ear, but the really important thing is we want the kid laying on their side with the affected ear we're using up, because we want the drops to stay in that ear. When they get up, it's going to just run out. So do something that'll give them an iPad, a phone, something to look at while they're laying there. Some people like putting cotton. That is not a great idea. If they really want it, you can put a cotton ball loosely on top of the ear, but we don't want to make it small and wad it down into that external canal, because it will wick up the medicine. And that is the goal, is to have the medicine against the skin in there and the tympanic membrane, not to be wicked into the cotton ball. Nasal drops. We've been doing these more often lately. So this is not a spray. They're actually sitting up. This is drops where they've got to be laying with their head down, so the drop, goes in and up into the turbinate. Sub-Q and intradermal. We have some medications that go sub-Q, like our insulin and heparin, and some of our immunizations. This is into the fat layer. Babies have plenty of fat. Young kids have very little fat usually. So you think about, do you have to pinch the fat up? You're not trying to pinch the muscle, just the fat. And then intradermal. This is for TB testing usually, or allergy testing. But this is something we do not want this injection to go out and be absorbed into the body. We want to keep it in the skin because we're using it to test for something. So this is where you're going to go just barely under the skin, and you want to get that nice bleb as you give it. This shows locations where you can give shots. Remember, infants were only using the thigh, the vastus lateralis. As they get bigger and their muscles are more developed, then we can start using the deltoid and the hip. We really do not want to use this postgluteal. It's not a great site, too much risk of hitting important things. Know your policy. The book says we can start using the ventral gluteal here, the hip, it's less than a year, and that is not the policy at Valley Children's. Valley Children's, they have to have been walking well for a year before we're going to use it. So atraumatic care, just like everything else, we're going to try and be as atraumatic as possible. So think about comfort positions. Kids probably want to be held rather than held down. If it's appropriate, use a topical before something. Make sure we educate the parents and the child of what's going to happen and why we're doing this. And then use all those safety precautions. Use your rights. Prevent med errors. When we're giving IV therapy, think about what you're giving. That's going to depend or determine what you start, what kind of IV you start. How long is it going to go for? What's the child's developmental level? Do we have to really protect it? Are they going to pull it out, or are they not going to? What is their status? How stable is this child? And what are their veins like? Have they had a lot of IVs already and we're down to very few usable veins? In general, the rule is to use the smallest gauge IV for the shortest amount of time necessary to meet the needs. You're going to see we do lots of PICC lines at Valley Children's, because if you're getting IV fluids or IV medications for more than a week, it's cost effective. A PICC line it's put in once instead of several IVs, so it really is less traumatic and cost effective. So when you go to start an IV, gather your equipment first. This child's anxious from the time they find out they're going to need it. So don't go in and out of the room multiple times, just getting them more anxious. Get everything first. At Valley Children's, think about using the treatment room. On kids, we prefer their hands over their wrists and upper arms. They just have so much fat. You're going to have trouble getting that vein. It's easy for it to roll away. So hands tend to work better. And feet, we can use the feet. But if they're walking, now we can't. Or even if they're pulling up and standing on it, they're going to knock it out. Ensure adequate pain relief. On infants, consider using the non-nutritive glucose drops, the sweeties. On older kids, put on their favorite movie, whatever. Prepare the site aseptically in terms the child can understand. I always say, I'm just looking now, I'm washing it now, here comes the poke, 1, 2, 3. So they have warning about the poke, but not enough time to do much. Use a barrier so you don't pinch the skin when you're doing the tourniquet, and then if needed, transilluminate the vein. At Valley Children's, they're kind of doing a study on transilluminating veins. One unit is doing it for all IVs to see if we have better success rates. Nutritional support. We can give nutrition enterally or parenterally, right? Enteral follows existing anatomy. So on neonates, sometimes OG, older kids, NG, nasogastric, orogastric. We do a lot of NJ tubes, so going into the jejunum, still through the nose, the tube down into the jejunum. Less risk of reflux, not quite as normal, right? Because you're bypassing the acids of the stomach, you're bypassing the duodenum where all those pancreatic enzymes enter. So that's our gastrostomies and jejuostomies. They're surgically inserted rather than the tube through the nose or mouth. You have to have a working GI tract if you're going to put nutrition into the GI tract. Remember, this is not sterile. The gut is not sterile. We can also give nutrition parenterally. This is sterile, and in fact, they are at high risk for developing sepsis just by virtue of being on that parenteral nutrition. We can do sometimes called PPN, partial parenteral nutrition, or just PN, parenteral nutrition. Must be through an IV. Depending on how concentrated it is probably needs a central line. It's probably too concentrated and will irritate and destroy a peripheral vein. TPN means you've got everything. What's missing from PN is the fats, so we add lipids to PN to make TPN, and you must have a central line. Sometimes these kids are eating but can't eat adequately, and so then we do kind of supplement with some PN, or sometimes they have no functioning GI system. But remember, this is an IV. It must be sterile. It's also an IV that's just really puts them at risk for sepsis between all that high sugar in the IV line and the central line. So we've got to be super careful with our sterile technique when we're doing this. And parenteral fluid or parenteral nutrition is hard on the liver. This is not something we do if we can get by with enteral nutrition. So when a kid does have an enteral tube, know your policy, check placement before you use it to give anything. At Valley Children's, for gastric, you're not required to get an x-ray. If you go jejunal, you are. So know your policy, but other ways to check are looking at the aspirate. What color is it? What pH is it? And after it's been in, is the marking the same? Has it moved at all? We're always looking for signs that it has been dislodged or is not in place. Is a child gagging, vomiting, coughing? Are we giving them fluids or nutrition down into their lungs? Or has it pulled up and they're just kind of gagging on it because it's reflexing up? So respiratory distress, that's really what we're looking for. When you give TPN, we've got to monitor vitals, use strict aseptic technique, really watch that insertion site. Don't break into that system. Keep that a closed system. Occlusive dressings, we're follow whatever your policy is, but flushing catheters as needed. We try and not do 24 hours. We try and give that kid a few hours a day off of the IV